didn't receive 4 or more hours worth of the IV antibiotics, then your baby will be monitored closely for those first, at least the first 12 hours after birth, which is when early onset Group B Strep infections are most likely to show. If you've previously had a baby with Group B Strep infection, then the baby is going to be monitored regardless for at least the first 12 hours, regardless of whether you've had the IV antibiotics in labour. Since the chance of a baby developing a Group B Strep infection after 12 hours is very low, neither you nor your baby will be given antibiotics after that point unless either of you become unwell. Next slide, please. We're often asked about what other countries do, so I thought I'd bite the bullet and have a slide on it. Quite a lot of other countries take a bit of a different approach to the UK to preventing early onset Group B Strep infections. Most high-income countries offer ECM testing to all pregnant women late in pregnancy, and then offer the IV antibiotics in labour when if Group B Strep is detected. Many middle-income countries offer a similar risk-based approach to ours in the UK. Research has shown that compared with a risk-based approach, a testing approach prevents more cases of early onset Group B Strep infection. It targets antibiotics better at women who are carrying Group B Strep rather than just happen to have risk factors. And it results in no significant difference in the number of women receiving antibiotics. And it does, as I said, prevent more cases of early onset GBS infection. Next slide, please. Excitingly, there is a trial being conducted right now to establish what's the best approach for the UK. The GBS3 trial will study 320,000 pregnant women and their babies in 80 trusts in England, Wales and Scotland. Half of the trusts will follow the risk-based approach, and the other 40 will be split into 20 using the ECM test for all pregnant women and 20 using a bedside test. The results are due in 2024, late 2024, and will inform national policy. So if you're from a trust and you don't think your trust is taking part in GBS3, please look into it. Visit our website, contact us. They are still looking for more sites to take part. Also, excitingly, a Group B Strep vaccine is in development. And that's the holy grail of Group B Strep prevention. It will prevent more cases than antibiotics in labour ever can, including late onset infections, stillbirths, maternal infections caused by Group B Strep. Sadly, it's at least 10 years away. Next slide, please. So in the meantime, yeah, how can we help? I mean, that was a real whistle-stop tour of Group B Strep. If you need more information, do talk to your midwife or contact us at Group B Strep Support. We'd love to help. We've got leaflets available, stickers for maternity notes, a confidential helpline, of course, a website, and support on Facebook and social media platforms. Do please get in touch if we can help. I'm going to go back to Ali. Thank you for your attention.
Thank you very much, Jane. Yeah, you may feel it's like a whistle stop, but actually there's a lot of information in there, I think. And certainly, I mean, you've had the lived experience of this, and I think you've been championing this now for a long time. And my hat comes off to you to just sort of keep beavering away and keep championing this to try and get everybody in this country and the government and everybody else and the Royal College of Obstetricians, etc., to just see the how we need to have this absolutely on our radars and what we need to do to try and prevent this and any baby that we can prevent from not being here with us in this world. It's worth the cause, isn't it? So yeah. Thank you very much for still keep plugging away at this and still beavering away at trying to make a difference for our future babies and our future parents to not have to go through the same as you. So thank you very much. I'm going to move on to our next honoured speaker. I'm really, really happy to have Dr. Elizabeth Egbase, who is a consultant obstetrician in Barts Health in North East London, who is going to talk to us now from the perspective of an obstetrician or a midwife, etc., of what happens if you have Group B Strep and you are having your care within a hospital, so or at a birth centre. So she's going to talk us through the sort of steps of what you might expect when you are pregnant and having care. So thanks very much. I'm going to pass it over to you, Lizzy.
Thank you. Thanks, Ali, for the introduction. So yeah, so what my plan is really to be able to do today is just to contextualize what Jane has told us and trace it through the journey of a woman with Group B Strep. I can't see the slides. Is it, next slide, please. Okay, so typically with all sorts of things, as with pregnancy and lots of the medical issues that happen in pregnancy, pre-planning is really key. And I think it's important for people to consider when they're planning pregnancies, what sort of preconception advice they are receiving or they would need, and as healthcare providers, what we should be discussing with women with regards to their next pregnancies, or if they are seen in the community, so in general practice, for example. And so I really would advise the advice to the women is to consider the conversations you may have about Group B Strep in pregnancy. And sort of advice for us clinicians really is to discuss the impact that Group B Strep will have throughout a woman's pregnancy. And we're going to think about the sort of the key questions that you need to be asking healthcare providers, and as healthcare providers we need to be asking our women, both in context of this index pregnancy and previous pregnancies. Next slide, please. So pre-pregnancy and booking. So if you're a woman and a pregnant person, and you're thinking, does having Group B Strep in a past pregnancy complicate my current pregnancy? Well, the answer to that is possibly. In your either pre-pregnancy or at your booking visit, really, we should, as healthcare providers, should be taking a really clear history and detailed history of a previous pregnancy, and consider what may be the important risk factors that would, complement what the details are important for risk assessment. And so that's risk factors that they have either in this pregnancy or certain risk factors from previous pregnancies, and Group B Strep is definitely one of those. So it's important for people in pregnancy that they understand that, as Jane has said, if you've had Group B Strep in your last pregnancy, there's still a 50% chance of carriage in this pregnancy. And for that reason, that group of people would be advised one of two things. So you need to think about, and we'll come on to what one of those things are. And then also it's important to think about and to disclose if in a previous pregnancy you've had a baby that's actually been infected by an early onset neonatal Group B Strep infection. So those are the most important things that as healthcare providers we need to find out. And if not asked, then as people in pregnancy, they should be giving that information and making that clear to us. Next slide, please. Is that okay? Yes. So so then if we're in a situation, so the question being, what will happen if I was Group B Strep positive in my last pregnancy, but my baby did not have Group B Strep? So as we've sort of discussed, you may be offered the following options on how you're managed. So you either have a choice of being just offered intrapartum antibiotic prophylaxis, and it's important to remember that we're offering women prophylaxis as a preventative measure. So it's not really to treat any infection, it's really to prevent the babies getting Group B Strep infections as they are passing through the birth canal. And again, it's important to remember that, because this isn't, if a woman is plan to have an elective cesarean section, then they would not necessarily, they don't need to follow the same pathway because the baby will not be going through the birth canal. But if you did not want to have the intrapartum antibiotics just as a prophylaxis, then you should be offered screening, and the screening swabs that Jane has described should be offered around 3 to 5 weeks before your estimated date of delivery. Now, for most singleton pregnancies, this will be between 35 and 37 weeks. But as clinicians, we know that twins, twin pregnancies and other pregnancies that are potentially complicated with have obstetric complications may require earlier delivery. So again, we have to always be reassessing and continuous risk assessment to decide when do we think the most appropriate time to be offering screening for Group B Strep. Next slide, please. So what does being Group B Strep mean for me and my baby when I'm pregnant? Well, it is a significant diagnosis, and that's a healthcare provider that all healthcare providers should be made aware of. So I've put this in here because obviously we know now in our post-pandemic world, a lot of people are getting results from investigations via text messages, and we also know that there are sometimes issues around communication between community healthcare primary care providers and secondary care providers. So if as a patient you've received a positive Group B Strep swab or Group B Strep has grown in your urine, then we would really encourage you to pass that information on to your midwives or to the doctors if you're coming to antenatal clinic. And obviously, if we're privy to that information and we in secondary care did the test, then we will be able to have access to that information. And it is important because essentially, if you've had a Group B Strep bacterial growth in your urine, you'll be offered antenatal antibiotics the same way that you would be for any urinary tract infection. The reason being that urinary tract infections can cause preterm labour, and we know that preterm labour obviously comes with its own morbidity issues for the baby and for mum. So we would want to prevent that by giving you antibiotics at that stage. But in addition, you have a Group B Strep positive in the urine. It means that it's likely to also be Group B Strep positive from the bacterial in the vagina. So in which case, it's also necessary to give you antibiotic prophylaxis when you are in labour. If you have a positive vaginal swab, you won't be needing antenatal antibiotics. And the reason why we don't give antenatal antibiotics is because we know that the membranes around the baby protect baby largely from these infections, and the babies pick up this infection as the baby goes through the birth canal. And so there is no infection. There's no reason to treat this infection until the baby is at risk, because Group B Strep is something that we carry in within it's a common genital bacteria that we can clear, and up to 35% of women may be Group B Strep positive early in pregnancy and may have cleared that bacteria by then. But so there's no need to necessarily treat it until we get to the stage of when the baby's at risk. Next slide, please. So again, in the antenatal period, when should I tell my healthcare provider about being Group B Strep positive and my history of Group B Strep? Well, I would encourage all patients to be sharing all the relevant information to every healthcare provider that's involved in their care. And we as healthcare providers should be taking detailed histories of the index pregnancy, so that's this pregnancy, and previous pregnancies, as we know that this is important for risk assessment. And it's also important that we're doing a continual risk assessment. Most recently, a lot of the maternity reports have been talking about the need and the value in continual risk assessment. So if you're Group B Strep positive, or you've had a history of having Group B Strep, or that you had a baby that had early onset neonatal Group B Strep, then it's really important that as healthcare providers we're aware of that. And even if you haven't, maybe you've seen the same midwife the whole way through your pregnancy, and then you're delivering in, you've been advised you need to deliver in the hospital, you need to declare that information again, particularly when you start showing signs of labour, if your waters were to go. And because at that stage, that's when your babies are exposed to the Group B Strep bacteria, and that's when at that point that they can start developing the early onset neonatal Group B Strep infection, and it will be at that stage that you'll be offered antibiotics. Next slide, please. So when would we as clinicians be worried about Group B Strep infections in labour? Well, some fetuses are more at risk of Group B Strep, of early onset Group B Strep infections than others. These are babies that are born under 37 weeks, babies that show the waters go before, so in situations where the waters go before the baby's born, so under 37 weeks. So we call that preterm, pre-labor rupture of membranes. So for example, 35 weeks pregnant and your waters have gone, but you haven't actually gone into labor yet. Again, your baby is at higher risk of developing a Group B Strep infection. Situations where women who are term, so who are over 37 weeks, their waters have gone, and it's been more than 24 hours and baby has not arrived. So that's more than 24 hours if somebody's outside of the hospital, but 18 hours usually if somebody's in the hospital. At that stage, we would recognize that this pregnancy, this labour, is at risk of being complicated by Group B Strep infection, and we would be offering intrapartum antibiotic prophylaxis. And women that are in labour that show signs that have temperatures, then again, we may be considering starting intrapartum antibiotic prophylaxis. If you were already on the prophylaxis antibiotics at that point, either because you had a positive Group B Strep test in the antenatal part of your pregnancy, or your waters have been gone for a prolonged period of time and you have a temperature, we would no longer then be talking about preventing an infection, we'd be talking about treating an infection. And sometimes in that situation, your healthcare provider may discuss with you, discuss changing your antibiotics to something that's what we call broad spectrum, that can cover more bugs, or more strongly treat any infection that may be present. Next slide, please. So after you've had your baby, I guess the thing people would want to know is, how would I know if my baby has a Group B Strep infection? Well, Jane's given us a really good rundown of the signs for early onset and late onset, but it's important to know that it can be difficult to diagnose Group B Strep immediately after delivery, and usually signs of infection will develop between 12 and 24 hours. So I think that's why when women have had babies and they were Group B Strep positive, and they're going to be monitored for the baby will be monitored for at least 12 hours, because we know that you're unlikely to see the signs that you necessarily need to see, or any concerning signs immediately after the delivery. And then the neonatal team will advise if the baby would be started on antibiotics or not, or if and we as healthcare professionals should be making sure that we're giving very, very clear, detailed handovers to our paediatrician, to our neonatal colleagues about the women that we've looked after if they're Group B Strep positive. And in addition, women that have got pyrexis, temperatures in labour, or required antibiotics in labour. Because again, these are risk factors that could lead to babies having early onset Group B Strep infections. And importantly for the neonatal team, these are the babies they need to be most aware of, so that they know which babies need to have the right observations and how frequently. Next slide, please. So the key questions as for pregnant people to be asking their healthcare providers. So really, I want to say that all questions are important. So if there's any conversations that you're being a part of, or that are taking place between yourselves and your healthcare provider, and you do not understand exactly the implications of what they're saying, or you feel that it's too medicalized, you should be able to ask questions. And I'd always encourage my patients to just continue to ask the questions until there is they have a clearer understanding, at least, of the processes and what to expect. So I would really encourage that to happen. Other questions that you should think about asking, and certainly don't hold on to this. If you're thinking, oh, I don't want antibiotics, what else can I do to protect my baby? It's important to know that currently we don't have any other avenues to protect the baby as effectively as intrapartum and antibiotic prophylaxis. However, different hospitals will offer different types of monitoring and postnatal care potentially for your baby. So it's always really important to be asking those questions. And also, if you're allergic to penicillin, you want to make sure that people know about that, and you may want to ask or want to know if you'll still be started on antibiotics, and you definitely will still be offered the antibiotics, and they're, again, different areas will have different antibiotic formularies depending on what the resistance rates are in those areas. And in that situation, which is why it's really important to make sure that there's clarity between you and your healthcare provider about your penicillin allergy status. And ideally, if you have any information about what happened or how you found out about your allergy, or how severe your allergy is, that would be even more important, because then again, it helps guide intrapartum antibiotic prophylaxis that you may be offered. That's it, I believe. Thank you.
Thank you, Lizzie. I think that's very detailed, but in the right way to get across the information that is required for anybody listening or out there who is pregnant. I also think it's a great refresher for any healthcare professional that might be dialed in and listening. Certainly for me, like I say, I might be a head midwifery, so not necessarily practicing on the floor, but it's always really helpful to just remind ourselves on the core points in caring for our women. So I think, thank you very much. That was extremely helpful. Before we go into the Q&A, certainly Safa is beavering away behind the scenes, collating all your questions. So please do start typing your questions in the chat box so that we're ready for that. Don't be shy. And Safa, I'm sure, will start to bring up our questions and let us know what's been coming in while we're speaking behind the scenes. But in summary, a huge thank you so far for our speakers and what we've heard. It really is a very important topic for us to disseminate the information. And that last summary slide, which has just gone very quickly from Safa, is about, please don't be afraid. Thank you. Don't be afraid to speak to your healthcare professionals. Don't be afraid to Google and log in to the Group B Strep support and all the information that they've got and their helplines. At the end of our webinar, there is a slide that has all the links as well as the media links. But yeah, I think a very important topic, and we've had that now from both Jane's perspective of lived experience and raising the awareness, and yourself of working in maternity services. So I'm going to hand over to Safa, and Safa, I'm hoping that we've been having lots of questions posed and beavering away in the background, collating our questions. If I can ask everybody who's on the panel, speakers, to now put your videos on so we can see your faces, and Safa will help to guide us with the questions that are coming in and who out of us might be best placed to answer those. So over to you, Safa.
Thank you, Alison. Moving into the question and answer section, we definitely have had some questions that have been emailed to us separately. and we are already getting questions in the chat as well privately, and I think so. I'm just going to go with the obvious one first. So there's a question around whether the slides for tonight's webinar will be shared. So the answer to that is yes. I have put in the chat the website, which is www.eastlondonhcp.nhs.net, and the webinar recording will be available within the next 48 hours alongside the slides, so do watch out for that, and we will be putting them up on our social media as well, and wherever you've heard about tonight's event. So we'll move in very quickly to our panel. So I am going to hopefully spotlight the three of you onto the main screen for everyone. So our first question tonight is thank you for yeah, so this is separate, but we have some very knowledgeable speakers on this call. Please, can I ask their general thoughts on the COVID vaccine, please? So I'm going to direct that one to Alison, Herron, and Dr. Elizabeth to take that question first.
Sorry, just repeat the question. Is it about the COVID vaccine? Or is it
Thoughts on the COVID vaccine? So slightly disconnected from tonight's topic, but still a very, very important theme.
Okay, I don't want to go into too much detail because we could talk forever. We've had 2 webinars previously on COVID vaccination. So I would urge anybody who's wanting any information on COVID vaccination to go onto our East London Healthcare website. 2 webinars, one that was for women and with any fertility, concerns, etc., around having a COVID vaccination, or pregnant and unsure whether to have the COVID vaccination. There is that webinar. We also did one for staff around how to have the discussions. And so I'm not quite sure, it's quite a broad spectrum question there. And I'm very keen that we don't get into COVID vaccination on this webinar for Group B Strep. But absolutely, at the end of the webinar, there is an email for the East London Healthcare Partnership, whoever it is that's asking around COVID vaccination. Please send us either your email or pose your queries through that route, and we will definitely answer your queries around anything COVID vaccination wise. But I really would this evening like to sort of keep our questions around Group B Strep, because we have had 2 very detailed webinars on vaccination. But we're very happy to talk to you outside of this webinar or answer your queries outside. Thanks, Safa.
Thank you, Ali. Yeah, I just wanted to touch on that quickly before we dive in. So the next question is, thank you for the information. Can we give IV antibiotics to all previous Group B Strep positive clients on arrival in labour? And that's a question potentially to Lizzy, yourself, and possibly kind of Jane might want to comment on that as well.
I hope you can still hear me. There's an airplane flying over. If somebody's had a previous Group B Strep infection in their pregnancy, then they should be offered intrapartum antibiotic prophylaxis. That discussion really should happen antenatally. But if it has not been, then it should definitely be happening when the patient arrives in labour. They may have already had that discussion antenatally, and they may have had a swab test. And if that test came back as positive, then again, that's even more reason to be that they should be given the intrapartum antibiotic prophylaxis. If that test came back negative, then they wouldn't need the intrapartum antenatal prophylaxis. However, there's no harm in having another discussion with the patient, and also making it clear that should any of the other risk factors come in play, then those antibiotics probably would be advisable to start those antibiotics at that time.
And can I just add to what Lizzy said? I mean, I agree with everything she said. It's one of those situations where it's really important to know if that woman has come in and she's had a negative Group B Strep test. It's really important to know which test, because a negative ECM test is a completely different ballgame than a negative standard hypervaginal swab. With a negative ECM test, you can be confident that Group B strep was not present when the swabs were taken and the results were given to the woman. But with a standard HVS or a standard swab that's just put on an agar plate, you get so many false negatives that it's much more of a worry.
Thank you to both of you for taking that question. The next question that we have came through by email, and that question is, how reliable are the antibiotics? And again, I think if we could use the same speakers for the last question.
So the antibiotics, I mean, there have been some significant sort of trials around the antibiotics, and we know that the antibiotics are reliable. I mean, we're talking sort of between most reliable when given more than 4 hours after, more than 4 hours before the baby's born. So if it's given for more than 4 hours before the baby's born, we're looking at reliability or effectiveness rates of about 95%, 97%. And that rate drops the closer the antibiotics are given prior to delivery. So we know that when you get to about 2 hours, then you're only really hitting about 50%. But even with that, for a safe antibiotics, very minimal side effects, then actually on balance, it is still effective. But yes, certainly most effective once you get, you know, at least a few doses of the antibiotics in prior to delivery. Would you say so, Jane?
Sorry, lost on mute. Yes, absolutely. Which is why the recommendation is to start the antibiotics as soon as possible once labour has started or waters break. The golden period, as Lizzy has said, is at least the first dose at least 4 hours before your baby is born, but no one can tell you exactly when 4 hours is going to be. So it's much more important to do it sooner rather than later. And as Lizzy has highlighted, the research shows that they are highly effective preventative medicine, and we are usually talking penicillin, which is an incredibly safe, well-used, well-tested antibiotic for the vast majority of women.
Thank you. The next question has come through in the chat, and I think we slightly touched upon this in the webinar, but it would be good to summarise on this point again. What about a woman who has had Group B strep prior to the pregnancy? Should they have antibiotics in pregnancy or not?
If a woman had Group B strep outside of pregnancy, they will not be given, there's no evidence that giving intrapartum antibiotic prophylaxis in labour for when they are pregnant is going to, there's no evidence for that use basically. Outside of pregnancy, without any other, outside of pregnancy, Group B strep is not going to be a risk factor for Group B strep infection in the newborn. That's what the evidence is telling us. Some women, if they've had Group B strep in their previous pregnancy, however, then that is something that we do, you know, we would want to know about, and again go down the route of either antibiotics or doing the appropriate screening tests. But most women who carry Group B strep, sort of, it is a common genital bacteria, and most people clear Group B strep very quickly. So outside of pregnancy isn't something that we would be as concerned about.
And I read the question, or I heard the question slightly differently. We wouldn't treat Group B strep carriage full stop, because you're not trying to eradicate it from the woman or the pregnant person. Group B strep is a perfectly normal, naturally occurring bacterium. It can come and go. It typically comes and goes over periods of months rather than days or weeks, which is why that testing window of 5 weeks before giving birth is so important. There is no evidence and lots of research of trying to treat pregnant women when when Group B strep's been detected during the pregnancy, and there is no evidence that doing that reduces the chance of the baby developing a Group B strep infection. And conversely, we do know that having antibiotics unnecessarily is not good for mum or the baby. So, the time the antibiotics work is when they are given either because you've got a urinary tract infection that's caused by Group B strep, or you have them in labour when they the antibiotics can pass to the baby. So baby gets a pre-birth dose of antibiotics, which can stop anything before it starts.
Thank you both. The next question that we have has come through on the chat. Again, should there be insufficient time to deliver the full dose of antibiotics during birth? And what would the monitoring of a newborn consist of? Same panel again.
I think that's actually quite specific to the unit in which you're delivering, and what potential other risk factors are there. I mean, if the baby has not had any antibiotics and we know that mum is Group B strep positive, then sometimes the neonatal team will discuss with the parents about giving the baby antibiotics themselves. If the baby has not had antibiotics, so if mum has not had antibiotics because she delivered very quickly and she's shown other signs of infection, then that conversation is more likely to happen, because they're going to want to be able to treat baby for any infection, well, protect baby from infection by giving antibiotics whilst investigating baby for infection, to decide how long those antibiotics need to last for. Outside of those, the absolute minimum that's going to happen in that situation is that the baby is going to be observed, within the hospital setting for at least 24 hours, usually.
Yeah, the Royal College of Obstetricians and Gynaecologists has put together, I mean, they have a green top guideline on preventing early onset Group B strep infection, and they've described quite clearly the key recommendations about when there's monitoring after birth and when it's not needed. So if you've had at least 4 hours worth of antibiotics before the baby is born and the baby's term and mum and baby are both well, then no additional monitoring. If there are risk factors, and as Lizzy was saying, that you haven't had 4+ hours, then there will automatically be monitoring. There's quite a move away from giving antibiotics just in case, but obviously if anyone is concerned that the baby is showing any signs of infection, we all know infection in newborn babies is really nasty. So if there are any concerns, they'll whack in antibiotics while they're running tests to find out what's happening.
Thank you very much. We'll just take a final question before we close, and that question is, can all women be screened for Group B strep? And back to you, Jane.
I personally think all women should be offered the opportunity of testing for Group B strep using a reliable test. I don't think it should be mandatory. I think it's all about personal choice. So at the moment, the recommendation at the moment, the National Screening Committee is the body that determines what conditions are screened for in the UK, and at the moment they are not recommending screening for Group B strep. The GBS3 trial that I talked about earlier, that will determine definitively, 320,000 pregnant women and their babies. That should determine definitively what is the best approach for protecting the babies in the UK. I personally fully expect that to be one of the 2 testing arms of the trial, and the results of that trial are due 2024 and will inform national policy and practice thereafter. I think that should be offering all pregnant women screening. I don't know if Lizzy wants to comment or would rather not.
I think it's very difficult. I think because of the nature of Group B strep, and the nature of, what we need a screening tool to be able to provide us, it doesn't always provide it that accurately in terms of, people that may screen positive actually still having the at the end. I mean, that's 25% might not have the pregnancy, that may not have it by the end of that pregnancy. And in addition, I think at the moment they're saying that there's probably about 10% of people that may screen negative who may actually be Group B Strep positive by the end of the pregnancy. So I think it's what I'm very, very happy that the GBS3 trial is coming, because that data I've just said is also old. There's also going to be, many other risk factors in play. And so I think, I really welcome the results of that study, because it looks like it's going to be quite large, very robust, and it's focusing on screening, which is really important. We need studies that are looking specifically at screening, rather than trying to get that information from other studies that have been published and sort of tracing it backwards.
Yeah, I think the GBS3 trial results will be so important, not just for the UK, but internationally as well. And I think one of the problems around testing in the UK is that still so often, despite the fact the ECM test has been recommended for use since 2017 by the Royal College of Obstetricians and Gynaecologists, by Public Health England way before that. So Osteology in 2017, Public Health England in about, I think it was 2006. A lot of hospitals aren't using it. And if you're using just a standard test to detect Group B Strep, the false negative rate is ridiculous. Yeah, I mean, it's just, why would you do it? Thankfully, there are ways women can get tested privately if that's what they want to do, and it's not available within their trust. And we vet organisations to make sure that they are following the ECM test, and we list them on our website. But actually, all trusts in the UK should be following the guidelines of the Royal College of Obstetricians and Gynaecologists and making that test available for health professionals to use. I mean, it's crazy. And then, as I said, I would absolutely lead with its patient choice. It's putting women at the centre of their care and what is right for them and what do they feel is right for them and their babies.
Thank you very much, Jane and Elizabeth. Some really important perspectives and points from both of you there. And apologies, we're right out of time for our questions. But please do remember that you can continue to share any questions that you have on Group B Strep and pregnancy, whether it's on the email address provided, and you can do that at any point after this webinar as well. I'm going to hand back to Alison Herron, who's going to close and provide details on where people can get support.
Thanks very much, Safa, and a huge thank you to Jane and Dr. Elizabeth. Absolutely great. I think we could stay talking and answering questions probably for another hour, I'm sure. But if there are more questions that we haven't got to, we absolutely will make sure that we'll put a full Q&A together. It will go out on our website and be disseminated. This webinar has been videoed, taped, whatever the old-fashioned way is. I'm showing my age now. Anyway, and it will be available and it will be disseminated. It'll be available for YouTube and we will disseminate it out. So please do revisit it at your leisure, watch again so that you can have all of your sort of questions answered again. And like I say, if you're a healthcare professional, it was a great refresher as well for what we need to do. I think Jane absolutely ended it there really nicely at the end of that question, that discussion with Lizzy. This is all about women's choice. This is about us making sure that women understand all about this, that they know what the options are out there for them. They know the care that they should be getting and that it's about their choice. And just my final note is if there are healthcare professionals on here and listening and they're working in their trusts, the Group B Strep free trial, check whether you've got it in your trust, and please get involved. Really encourage your staff to be involved in that. it's really great. And the more hospitals that are involved, then the better information that we can get to really make a difference going forwards. So I'm going to bring us to a close. I really want to thank everybody who's joined in, who's dialed in to listen. Thank you very much for your support on all of our webinars. I hope you found it useful. Have a great evening, and hopefully you're going to run into a bank holiday weekend and get some rest and hopefully enjoy some sunshine. So thank you very much to the panel and all those that dial in. Have a great evening, and we'll see you again for another webinar with North East London LMS very shortly. In a few weeks' time, we'll be disseminating what the next one is. So thank you. Take care.
Thank you, everyone. We'll just wait a couple of minutes for people to exit the webinar before we debrief. I will just be removing people who aren't part of the panel just now, so please don't be offended. It's just so that we can have a quick debrief. Zoom isn't allowing me to remove people without a reason, so okay, I think that's back to us all. First of all, well done, everybody, for doing such a great job at that. Yeah, especially to Lizzy, Ali, and to Jane, I think, who just did a phenomenal job at explaining such a brilliant, such a fun, well, really important theme, but it was really important that we do. Still got people joining, which is interesting. So,
oh dear, we got to start all over again and do another hour. And slide one. Let's go.
Yeah, I'm just gonna stop recording because